Well, a very good day to all of you, and so nice to see all of you joining in and sending in your greetings, waving at us. It's delightful, actually, just to be back from Austin, Texas, from the ASC meeting, where Dr. Gan and I met just a few days ago. Yeah, right now, maybe Jenny, you and I should have worn our denim and Texan hats just to continue the party here. But it's a really great pleasure to welcome you, Dr. Gan, uh, working at the MD Anderson, the very prestigious institution in Houston, Texas. Jenny completed her residency in New York at Mount Sinai, surgical path as well as cytopathology. She did a PhD in molecular physiology and medicine at the University of Virginia. She's currently director of cytopathology fellowship program. And amongst her many research interests, of course, she's well known for her pancreatic and thyroid cytology interests, but also of interest today to us. And her talk is the application of cytopathology material to cancer research. So her talk today will really relate to immunostaining and different type of cytology preparations, including controls and validation. And this, of course, is of clinical value in the histological and categorization and typing of tumors, determining the site of origin, and ultimately benefiting patients, particularly in those who are suffering from breast cancer, lung cancer, or head and neck cancer. So welcome, Jenny, and I will let you share your screen. I think you already are. And welcome, everybody, and enjoy the next hour. Please type in your questions into the chat box, and I will pick them up at the end. Thank you.
Thank you so much, Dr. Chandra, for your nice introduction. And hello, everyone. I guess it's because it's an international meeting, so I don't know your time zone. But anyway, how is everyone? And I'm Jenny, so I'm from anatomic pathology. So I'm really honored to be invited to give a talk today for the IAC webinar. And today's talk, actually, I'm as just introduced, I'm going to talk about immunochemistry cytology staining. So I have nothing to disclose. So today's presentation have a few parts. To start, I will discuss some unique challenges ranging from like various specimen preparation methods, the validation process, and setting up controls. And after that, I will dive into a systematic method for handling cytology cases. This approach centers on identifying tumor lineages and using specific ICC markers for different organs. And finally, I will touch briefly on how ICC contributes to personalized cancer care, especially focusing on lung and breast cancer. So let's get started. So what are the special issues related to ICC? As we know, there are many different cytology specimen preparation methods, which have variable effects on ICC. As such, employing ICC requires rigorous validation. Moreover, many cytology specimens actually, they have very limited material precluding cell block preparation, such as CSF. So luckily, actually, we have two very powerful tools that can help us for ICC. First one is that we can use previously stained smears, especially perpendicular stain slides for ICC. And secondly, actually, we can use a cell transfer technique, which can produce multiple slides from one smeared slice to do bunch of ICC. Because of the numerous variables inherent in cytology specimen, comprehensive validation becomes very essential for factors that are present in this process. Which these factors include, for example, connection media, preservatives, fixatives, staining methods, glass slides, goes on and on. So validation should be carried out under realistic use or within a simulated use environment. So the validation should reflect the specimen types and processing of patient samples. So for non-predictive markers, actually 10 positive and 10 negative cases will be needed for the ICC validation. However, for predictive markers like ER, PR, HER2, etc., 20 positive and 20 negative cases will be required for each category. The validation process aims for an expected concordance more than 90%. So what are the different cytology preparations? This slide basically illustrated various cytology slide preparation, including liquid-based methods such as thin prep and sure path, and pepiniculum stained smear slides and deep quick stain slides, as well as unstained slides prepared from cell pellet using cytospin or using formalin-fixed paraffin-embedded cell blocks. And fixatives used for each of these different preparations will include methanol for thin prep, ethanol for sure path, and direct pepiniculum stained slides, and also formalin for cell block. Regarding ICC, according to literature, it's actually sure path and pepiniculum stained slides demonstrate comparability to formalin-fixed paraffin-embedded samples. In contrast, thin prep and diff quick might exhibit a false negative and a lower intensity in ICC results. Therefore, rigorous validation is necessary for majority of these smears preparation, while cell block requires minimal preparation. So literatures have reported different fixatives may impact the immunoreactivity. For instance, findings from this study show that ethanol fixation significantly inhibit Ki67 when they use the MIB1 clone, whereas this effect, it doesn't have the effect for clone 39. Multiple studies have highlighted that both methanol and ethanol fixatives can influence antigen configuration. And also this alteration actually cannot be reversed or recovered by post-formalin fixation. So as I mentioned, there are two powerful tools. One is the ICC on smears. So at our institution, we have validated focusing on some of the nuclear ICC stain markers on smears and successfully used them in our daily practice. As a picture shown here, all these are ICC performed on smears, including like PAX8, P40, TTF1, etc. So typically, these stains serve to confirm diagnosis with no malignant history, you can imagine, especially in cases with limited specimen where there is insufficient material for cell block preparation. And the second powerful tool is cell transfer technique. As shown here, from one cellular smears, you can transfer the cells to multiple slides. For example, in this case, we can transfer to 8 slides, and then this process allows us to use these divided slides for multiple markers as illustrated here. On the flip side, materials from multiple cases can be transferred onto a single slide as shown here. If you have 8 cases, actually you can get a piece of the material and put them on one slide. So here is the example that I put 13 cases of metastatic prostatic adenocarcinoma to perform PSA, especially so this proves to be a cost-effective method, especially in a research setting. So when employing smears for ICC, it's very crucial to incorporate a range of controls comparable to the types of smears used. At our institution, we actively prepare comparable smear controls to ensure robust ICC analysis. In cases where a comparable slide control is not available, and then tissue control can serve as a substitute with a disclosure included. For example, like we can use malignant effusion, like the cell pellet, or actually we go to the grocery room, get a fresh surgical specimen, and then we prepare batch smear control for the markers that I just mentioned. So in the following section, my emphasis will be on the practical application of ICC, particularly emphasizing on lineage determination and organ-specific ICC markers. So let us start with a case. So this case is a CSF from 36-year-old male, no prior history, presented to an outside ER because of some neurological symptoms. So brain MRI showing a widespread leptomeningeal carcinomatosis. Outside institution get a CSF connected and was signed out as malignant fibrometastatic carcinoma. The slides were not sent to us. Patient presented to our institution and we connected the CSF. As you can see here, so this is a deep quick stain slides, quite cellular. And when we go higher magnification, we can appreciate this kind of singular dispersed epithelial cells that has round nuclei, kind of moderate cytoplasm, and also you notice lots of cytoplasmic blurbs. And if you pay attention, actually, there are quite few like binucleated cells. And in some area, you see some cells have this kind of tiny granules. Whether they are pigmentation, I'm not 100% sure. Of course, I don't have the perpendicular stain slides here. And the reason is in our institution, regularly for CSF, we prepare two slides. One is stiff quick and one is perpendicular stain slide. So the perpendicular stain slide has been used for IHC. So in this scenario, there is only one IHC that I can perform. And this is the immunostaining. You can see here has a good nuclear staining. So guess what it is? SOX10. So unfortunately, actually, this patient confirmed to have primary leptomeningeal melanoma, and patient passed away in a few months. So here is a structured tiered approach for a cytology case workup by incorporating ICC. With an unknown case, the initial step actually first is ask whether it's a neoplastic and a benign process. And subsequently, we aim to identify the lineage origin of the tumor cells. For example, for the case that I just presented, right? So in the outside thing, the patient has carcinomatosis, and fever is a metastatic carcinoma. So it's very important to do a lineage determination. So we aim to identify the lineage origin of the tumor cells among epithelial, melanocytic, hematopoietic, mesenchymal, and some other rare tumors. And once the lineage is determined, the next step is to identify the subtype with each lineage, together with, of course, with morphology evaluation. For example, in epithelial lineage, you might think is it adrenal, is it squamous, neuroendocrine, and for melanoma, what type of variant, which variant, like spindle cell, desmoplastic, etc., goes on and on. So it is important. Following this, we proceed with the site-specific markers if it is applicable. It is important to know that actually selection of an efficient yet concise panel of markers should be based on patient's clinical, medical history, clinical radiological coordination, as well as the morphology evaluation. So for example, if you think it's adenocarcinoma, probably we can apply some like lineage markers, TTF1, PAX8, CDX2, GATA3, etc. And then of course, there are some lots of tumors, they do not have site-specific markers. In this situation, we need to crucially use our ICC panel, as I just mentioned. So for cases that need to be worked out from lineage determination, the first tier panel of markers include pan-keratin for epithelial lineage, and for pan-melanoma markers for melanocytic differentiation, and for hematopoietic lineage markers to identify these lineages respectively. As a first-line screening marker for epithelial lineage, we use AE1, AE3, which is expressed in majority of epithelial neoplasm. However, a few exceptions exist. For example, hepatocellular carcinoma and adrenal cortical carcinoma, they are negative for AE1, AE3. On the other hand, non-carcinoma malignancy may show variable AE1, AE3 expression. For example, mesothelioma, epithelial angiosarcoma, synovial sarcoma, desmoplastic small round cell tumor, chordoma, actually, they all can have high expression of AE1, AE3, right? So commonly used melanocytic markers that I used here, and for the initial lineage determination, we usually use a pan-mel cocktail, which is commercially available. So CD45 is a highly specific for hematopoietic cells. However, a few hematopoietic neoplasm, actually, they might be negative for CD45. For example, anaplastic large cell lymphoma, Hodgkin lymphoma, lymphoblastic lymphoma. So we just need to keep that in mind. For mesenchymal markers, depending on the lineage. So when diagnosing metastatic melanoma, certain markers play a crucial role that I just listed in this table. You can see their sensitivity and specificity. And for cytology, actually, to diagnose metastatic melanoma, we highly recommend to use like nuclear markers here. I list our SOX10 and MITF1. And the very recently newly used the markers that I got to know is called PRAME. All these are nuclear staining markers. However, please remember, actually, their specificity might not be good. For example, SOX10 actually can be positive in clear cell sarcoma, MPNST, even triple negative breast carcinoma. Additionally, like a PRAME, actually, they can be positive in some sarcoma, like synovial sarcoma, myxoid liposuck, and subsets of carcinoma. Although it's a good marker to differentiate between melanoma versus nevus, of course, this doesn't apply to cytology. And MITF1, although it's a nuclear marker, actually it's not specific, and it's highly positive in some like spindle cell carcinoma, BCC, etc. So next, I will discuss organ-specific markers of epithelial neoplasm with a focus on their relevance in a metastatic setting. So let's talk about thyroid and parathyroid first. Regarding thyroid lineage markers, TTF1 and PAX8 are commonly used, and sometimes we will include thyroglobulin. A few key points worth highlighting. First, in anaplastic thyroid carcinoma, we know both TTF1 and PAX8 expression is decreased, with PAX8 actually has slightly higher sensitivity than TTF1. Of course, lots of time we need to use a PEN-CK to confirm it's a carcinoma. And in the follicular cell-derived neoplasm, hyalinized intrabacular tumor, which is a low-risk neoplasm, and this entity is positive TTF1 PAX8 and has a membranous staining for Ki67. For C-cell-derived imaginary thyroid carcinoma, it's positive for TTF1, and please remember it's negative for PAX8. Of course, other markers such as neuroendocrine markers, calcitonin, CEA are positive. And for cribriform molar variant thyroid carcinoma, which was a type of PTC, and in most updated WHO book, it's now classified as unknown histogenesis, and it's positive for TTF1, while it's negative for PAX8. So for sclerosing mucoepidermoid carcinoma with eosinophenia, as well as salivary type mucoepidermoid carcinoma, they have variable expression of TTF1, PAX8, and thyroglobulin. And other entities like thymic tumor within thyroid, as well as other type of salivary gland type tumor in thyroid, they are generally negative for TTF1 and PAX8. For example, so here, these two images shows HE and staining and PAX8 staining. You can see this area shows imaginary thyroid carcinoma in a background of normal thyroid tissue. And the PAX8 is negative in the imaginary thyroid carcinoma, and it highlights the background follicular cells. So this is an example of thyroid sclerosing mucoepidermoid carcinoma with eosinophenia. It's a cell block. And you can see this kind of squamous cell clusters with increased eosinophils, and these tumors, in this case, is positive for P40 and TTF1. And PAX8 is negative, I didn't include. So in cytology, distinguishing between a parathyroid lesion, such as intrathyroid or parathyroid adenoma, versus a thyroid neoplasmal lesion can be essential. In this scenario, we can employ two nuclear markers, GATA3 and the TTF1, which will be efficient for this purpose. You can see TTF1 is strongly positive on the smear slides for thyroid follicular cells, and the GATA3 has good sensitivity for parathyroid cells. Next, let us move on to salivary gland neoplasm markers. This table summarizes the IHC surrogate markers for molecular genetic alterations, as well as some useful markers for the commonly encountered salivary gland neoplasm entities, such as MIB for adenoid cystic carcinoma, NR4A3 for actinic cell carcinoma, and the PANTRAC could be very useful for secondary carcinoma, and PLAG1 HMGA2 is good for pleomorphic adenoma as well as carcinoma XPA. Let's look at those entities one by one. Adenoid cystic carcinoma usually has a genetic signature for translocation chromosome 6/9 or 8/9, which led to MIB fusion and subsequent activation of MIB gene. Although the MIB protein overexpression is frequent in adenoid cystic carcinoma, its diagnostic value actually is restricted due to its less than ideal specificity, because Sometimes there is weak and focal labeling of MIB in some other benign and malignant entities, such as pleomorphic adenoma, basal cell adenoma, epithelial myoepithelial carcinoma. And this study shows that if we use a strong MIB staining, hold on a second. Sorry, I just have my AA outside. So when they use a strong MIB, actually this has a good specificity. Of course, the sensitivity is lower. And if they use any MIB staining for adenomyocystic carcinoma, although it increased the sensitivity, but because the weak staining in other entities, it decreased the specificity. Most cases of actinic cell carcinoma exhibit translocation of chromosome 4/9, leading to increased NR4A3 expression, which is a nuclear marker as shown here. So here is a cell block for actinic cell carcinoma. In this area shows the carcinoma component, and in this corner, these are benign actinic cells. And if you take a look, NR4A3 has a good nuclear staining in the tumor cells where they are negative in the benign actinic cells. And the dark one actually is a good marker because it has characteristic staining pattern. You can see in the neoplastic cells, it has the luminal and cytoplasmic staining pattern. Compared to the benign cells, actually majority of them has a basal staining pattern. So in cytology, we usually prefer nuclear markers, and in this case, NR4A3 has good specificity compared to dark one. Then secondary carcinoma, which is not quite often, but we do see sometimes in practice. For example, this is one of my examples. We concerned about secondary carcinoma, and then we can use markers including, for example, S100, GCDFP, hemoglobin, and in this case, I did an N-track immunostaining, and you can see there is a good nuclear staining, and of course, there's strong S100 staining. So compared to its close mimic actinic cell carcinoma, secondary carcinoma is negative for NR4A3 and the dark one. Neoplastic thymic epithelial cells are usually positive for keratin and squamous cell markers with a diffuse meshwork pattern. It's worth noting that thymic epithelial cells, actually, they are positive for PAX8 polyclonal antibody. And this staining actually is negative when we use monoclonal PAX8 antibody. Thymic carcinoma, accounting for about 20% of thymic epithelial neoplasm, primarily comprises squamous cell carcinoma, representing about 80% of cases. In this case, CD5 and CD117 are positive in about 80% of thymic squamous cell carcinoma, but they are rarely expressed in thymoma, and their expression is very low in lung cancer. So there are some additional thymic epithelial markers that I recently just noticed from literature like FOXN1 and CD205. They might be valuable in confirming the thymic origin. However, these markers might not be readily available because they are not available in our lab. Let's move on to lung. Lung actually is quite often we encounter lung cases, and the most common used markers will be TTF1, P40, neuroendocrine markers, including nuclear marker INSM1. And few points that I want to point out. One is that there are two commonly used TTF1 clones. One is 8G7G3 and the other is SPT24. So the former has a lower sensitivity but with a higher specificity compared to SPT24. Another thing that I would like to point out is for P40. So literature recommend to use a cutoff of 50% of the tumor cell being positive to suggest a squamous cell carcinoma. And if it's less than 50%, I guess morphological review is very important. And for neuroendocrine markers, actually, INSM1 is really a good marker. Nuclear staining has a good specificity for breast. So when discussing breast lineage markers, two noteworthy ones are GATA3 and the recently identified TRPS1. GATA3 is widely used due to its nuclear staining pattern, and also it has a higher sensitivity compared to few cytoplasmic markers such as GCDFP15, hemoglobin, which typically are cytoplasmic and very focal. However, actually GATA3 has limitations. We we might all know, right? Particularly actually, for example, their sensitivity is relatively low in triple negative breast cancer. Its expression may vary from like 15 to 60%. Moreover, it is expressed in various types of tumors such as urothelial carcinoma, like paraganglioma, parathyroid tissue, etc. And so diminishing its specificity, TRPS1 instead actually demonstrated sensitivity comparable to GATA3 in GATA3 positive metastatic breast cancer, and it has a better sensitivity than GATA3 for triple negative breast cancer. Additionally, TRPS1 tends to be negative in most GATA3 positive non-breast tumors. However, there are a few points that I would like to highlight. In apocrine carcinoma, TRPS1 is usually negative while GATA3 is positive. And in rare breast actinic cell carcinoma, adenomyocystic carcinoma, and high-grade neuroendocrine carcinoma, both markers tend to be negative. And in squamous cell carcinoma in general, not limited to breast, both markers can be weakly positive, and please remember, it doesn't signify breast origin. And moreover, TRPS1 might show positivity in certain gynecological serous carcinoma, for example, in ovarian serous carcinoma. Regarding markers for GI origin, CDX2 and SETB2 are considered because they are nuclear markers. CDX2 is associated with in general GI primary origin and can appear in lung and GYN enteric type adenocarcinoma. On the other hand, SETB2 tends to indicate a preference for lower GI region. Some studies actually have indicated that SETB2 is more precise marker for colorectal origin compared to CDX2. However, actually, these markers show near equivalence when interpreted at their optimal expression levels. So pancreas, differentiating between pancreatic ductal adenocarcinoma from its mimics such as pancreatitis sometimes pose a challenge in cytology, as we know. Studies have indicated that few markers, S100P, IMP3, MESPEN, and PVHL and DPC4 or SMAD4 can serve as a surrogate biomarkers aiding in this differential diagnosis. Positive staining for these three markers and the loss of expression for these two markers tend to support the diagnosis of adenocarcinoma over mimics. So the dual staining out of these three markers actually demonstrated a reported sensitivity about 94% and 100% specificity. So these markers, when utilized on cell block from pancreatic FNA, may help mitigate false negative results. Additional pancreatic tumor markers, including beta-catenin neuroendocrine markers, trypsin, and SOX11, which can serve as a sensitive marker for solitary pseudopapillary neoplasm. So among these markers, beta-catenin positive staining is nuclear and cytoplasmic, which is positive in solitary pseudopapillary neoplasm. But remember, about 10% of pancreatic neuroendocrine neoplasm, they can be positive for beta-catenin too. So in this scenario, actually, a combined IHC markers might be needed to differentiate neuroendocrine neoplasm from solid pseudopapillary neoplasm, as well as acini cell carcinoma in pancreas. At times in cytology, distinguishing between hepatic primary cholangiocarcinoma or metastasis becomes necessary. The optimal combination for hepatic origin includes arginase-1, hepa-1, and glypican-3. Among them, arginase-1 is the most specific markers in differentiating hepatocellular carcinoma from non-HCC. It has more diffuse staining pattern, but remember, it can be seen in pancreatic adenocarcinoma. So it is recommended to use these three markers as a panel in distinguishing HCC from metastases. In case of Mullerian origin, we commonly employed PAX8 as a lineage marker alongside ERP16, WT1, P53 to subtype the tumor if needed. Recently, actually, SOX17 has emerged as a highly specific marker for ovarian and uterus carcinoma similar to PAX8. However, it doesn't exhibit expression in thyroid and kidney tumor, yet it shows some positivity. It shows positivity in angiosarcoma. The expression of SOC17 in cervix is lower compared to PAX8. The frequently employed adrenal markers including inhibin, menin A keratinine, and SF1. When combined with consideration of the lesion location, they connectedly exhibit good sensitivity and specificity. Among these markers, SF1, steroidogenic factor 1, stands out with the highest specificity as well as its nuclear expression pattern. So SF1 belongs to a steroid receptor superfamily. It's a sensitive and specific marker for sex cord stroma tumor of the ovary, and also it can aid in differentiating adrenal cortical neoplasm from its mimics. So for example, here is a case presented with a pancreatic tail mass, and it's a quite challenging. And so with a cell block, we kind of consider, for example, neuroendocrine neoplasm and a few mimics, and finally it turns out to be an adrenal rest. And on the cell block, you can see it has good SF1 nuclear staining and it's focally positive inhibin A. Confirming a metastasis from the prostate is a frequent scenario in cytology. Among the markers listed here, NKX 3.1 stands out as the best choice due to its nuclear localization and its specificity, although it has been reported to be positive in a subset of lobular carcinoma, but as you can imagine, it usually doesn't come into as an issue. And compared to NKX 3.1, there are quite a few other markers for prostate primary, such as PSA, PSAP or PAP, prostate, PSMA, but they are all like a cytoplasmic or memory staining pattern, and also like a PSA and a PAP. They are not quite specific. They can be seen in salivary gland neoplasm, and also their expression is decreased with hormonal therapy for prostate adenocarcinoma. Our research revealed that NKX 3.1 serves as a very reliable marker for metastatic prostatic adenocarcinoma on smears in different grade of Gleason grade of metastatic prostatic adenocarcinoma. However, as shown here, actually NKX 3.1 is negative in all small cell carcinoma differentiated from prostatic adenocarcinoma. In all the cases, about 10 cases in our study. Few studies have reported that there is low expression of NKX 3.1 in small cell carcinoma transformed from prostatic adenocarcinoma. Of course, predictive and prognostic biomarkers in metastatic prostatic cancer can be evaluated through ICC on FN specimens. So ICC can be very useful for therapeutic and prognostic application in metastatic prostatic cancer. We are aware that metastatic RCC can unexpectedly arise years later in cytology scenario, right? Subtyping RCC in cytology is, in my mind, is impractical, and it's not really needed. Typically, confirming a renal primary origin is adequate. So usually it can be achieved using PAX8 or PAX2. If required additional markers like AMACAR, CD117, CA9, and RCC might be included. Regarding urethral origin, GATA3 proves sensitive, but we know it's a specific marker. So a panel of markers such as P40, uroplakin-2, uroplakin-3, and thrombomodulin can be included for this purpose. It's frequent in cytology to differentiate between mesothelioma and adenocarcinoma. This differentiation is relatively straightforward. We can choose to use two mesothelioma markers from keratinine, D240, WT1, CK56, and along with two adenocarcinoma markers such as MOC31, BER-EP4, claudin, and sometimes you can, of course, add organ-specific markers if necessary. This is an example of actually pelvic washing. Obviously, it's like mesothelial cells, and you can see this cross-reaction of the mesothelial cells with MOC31 and BREP4, and they are also positive keratin and WT1. Among the epithelial markers, Claudin-4 is quite specific for epithelial. Indeed, now those individual mesothelial markers are entirely specific. For example, CK56, we know they are positive in squamous cell carcinoma and urothelial carcinoma. WT1 is widely expressed, for example, in serous carcinoma, Wilms tumor, sex-core stromal tumor, goes on and on. Keratin, I would just mention, is positive in cortical tumor, sex-core stromal tumor, adnexal tumor, etc. Our challenge actually in cytology lies in distinguishing reactive mesothelial cells from mesothelioma. In a recent review paper, they evaluated biomarkers for this differentiation, and they concluded that BAP1 loss, MET-tapton loss, and P16 fish exhibit high specificity, but less than optimal sensitivity when used independently. Meanwhile, historical markers such as GLUT1, IMP3, actually they demonstrate unsatisfactory diagnostic performance and should not be solely relied upon for diagnosing mesothelioma in effusion. So in the next about 5 minutes or so, I will explore the impact of ICC in tailoring personalized care of cancer patients, emphasizing its role in lung cancer, breast cancer. This table actually summarizes the ICC could be used as a biomarker for targeted therapy, focusing on non-small cell lung cancer and breast ovarian cancer. As you can see here, IHC for ALK1, ROS1, BRAF, TRAC, PD-L1 is quite useful for non-small cell lung cancer, and ER-PR, HER2, Ki67 could be very useful for breast and ovarian cancer, and MMR could be useful for colon and endometrial carcinoma. As recognized, the BRAF V600E mutation holds significant importance in managing thyroid cancer and melanoma patients. PD-L1 testing has become nearly essential for various malignant diagnoses, so extensive validation studies regarding ICC have been widely published as listed here. Regarding PD-L1, there is a notable high agreement between cell blocks and histology samples. Direct smears might also prove equally applicable. However, a caveat exists. Criteria for identifying PD-L1 positive tumor cells in smears, cytospin, or liquid-based cytology might be different from those in biopsy or cell block. This discrepancy is due to the less distinct accentuation in uncut cells due to some physical reasons. So here it shows PD-L1 expression on cell block derived from malignant fluid, demonstrating strong correlation with histological samples. Similarly, ALK, IHC, or ICC has been the standard for ALK testing, particularly with commercial Ventana ALK acid, which has high accordance with ALK fish. While ROS1 ICC presently serves solely as a screening test for non-small cell lung cancer, because actually it has it doesn't have a standard reporting for ROS1, and also its staining is heterogeneous. So the reliable assay for ROS1 fusion is still like PCR or RNA-based NGS testing method. Regarding NTRK fusion, there is an FDA-approved Pan-Track IHC assay is available for screening purpose, and the standard method for detecting NTRK fusion is still RNA-based NGS, and FISH is not efficient because they are NTRK 1 to 3 fusions. In breast cancer, alterations in marker status are frequently observed in metastatic breast carcinoma, such as changes in ER can be seen up to 56% of the cases and HER2 in up to 38% of cases. So ICC becomes significant when dealing with scenarios that, for example, there is no core biopsy, and when it is a bone metastasis or when it is malignant effusions. It has been reported that cell block and histology has high concordance rate, especially for ER and HER2. ICC could serve as a practical and cost-effective alternatives for conducting microsatellite instability testing on mismatch repair proteins, MMR. So in summary, ICC stands as a very potential tool when supported by proper validation and controls. Its primary utility lies in confirming the lineage and also identifying the organ-specific primary site. So ultimately, ICC emerged as a robust and practical choice for precision medicine and targeted therapy. And thank you so much for your attention.